starting to, like the morula, when we start to separate the cells, they start dividing into the multiple cells. As it's traveling to the uterus, then we go to a blastocyst, okay, and then we implant. Okay, so during that stage is when we start getting into some of those congenital malformations, such as like Down syndrome is happening during that pre-implantation period as well, because that's when the transfer of the genetics is happening. Okay, so once we become fertilized, we're at a zygote, we start separating out our cells into multiple cells within it. We go to a morula, a blastocyst, and then we implant. And then that's when everything really starts to take off from there. So when we implant, our blastocyst, which is full of a bunch of different cells, goes from a trophoblast to an embryoblast. And that's when we're starting to get the different separation of the cell. So we start out with a big cell, a ball of cells, and then when we get into the blastocyst and the trophoblast is when we start to separate out those cells, because some of them, the trophoblast is going to become that supportive tissue that's going to support that embryo as it develops to get all of its nutrients and things like that. The embryoblast layer is going to give rise to the embryo. So we're still cells at this point, okay, but they start to separate out from being a bunch of balls of cells to separate cells out on the outside of it. Trophoblast is the supportive tissue. Embryoblast is going to be the embryo. Okay, so again, that's all within our pre-implantation period. So go from a zygote, we start separating out the cells, and we go to multiple cells all the way down until we get to implanting into the uterus. And this is where you're getting the trophoblast and the embryoblast based on the separation of those cells. So we've gone through all the process of separating cells, we've implanted into the uterus, so we've hit into the stage of that embryonic period. Okay, so we're going to start developing the embryo. So hopefully you remember our bilaminar disc, right? Our trilaminar discs. Okay, so that's when we're getting the two separation of parts of the embryo. Within that trilaminar disc, we get the three different layers that give rise to different parts of our body. Okay, we have the ectoderm, the mesoderm, and the endoderm. Ectoderm, if you remember E, okay, especially when it comes to tooth development, our enamel, in a sense, comes from our ectoderm. So if you think E for enamel, ectoderm, epidermis also comes from the ectoderm because it's kind of covering the outer part of the body. Mesoderm, okay, is the middle, so connective tissue, but also other layers of the tooth. So if you can remember ectoderm being E for enamel, and then the middle, okay, being everything else of the tooth. So your dentin, your pulp, your PDL, all that other stuff is going to come from the mesoderm. So ectoderm for enamel, mesoderm for the rest of the tooth. And then if we think endoderm, if you think endoscopy, so when they go in and they take a camera and look at the inside of your body, right? If you think endoscopy, you can remember endoderm being kind of everything within like our digestive tract or the inner part of our body. Okay, but it also gives rise to a respiratory epithelium because you're going kind of close to that way. So I don't know 100% what's on your boards, but if they come up with these type of questions and they're trying to ask you which part of the embryo, those layers of the trilaminar disc, gives rise to what big parts, major parts of our body, especially like tooth development or other parts of it, you can kind of start to find ways to remember which gives rise to each one, which is between the three. So epidermis, outer part of the body, ectoderm. Endoderm, just think endoscopy, everything on the inside. Questions so far?
So the primitive streak makes the bilaminar disc.
Right. Right. So your primitive streak is going to start to develop, right? And so you start out with, initially, you start out with just the bilaminar disc. Because it's just two layers. It's the epiblast layer and the hypoblast layer. That's all it is. Right? And then as the primitive streak starts to go further down, it's going to start kind of developing that layer starts to thicken in a sense, and the primitive streak starts to deepen. Okay, that's when you go to the three layers, eventually becoming ectoderm, mesoderm, and endoderm. So yes, you start out with the beginning of the primitive streak starts at bilaminar. As it develops and as it deepens, and you go to the trilaminar. The primitive streak is also going to give rise, in a sense, to the digestive tract as it starts to, and like the spinal cord, the major nervous system, as it starts to fold. I have a slide here coming up that will show you guys that. But the biggest part I want you to remember is your three layers: your ectoderm, mesoderm, and endoderm. Because when it's still the bilaminar disc, it's really not anything substantial to the body. Eventually, it gives rise to the trilaminar disc, which then gives rise to major parts of the body. And if you guys still have your textbook, you can see all the different things that actually do come from these three layers. These are just kind of the basic of what it comes from, and especially when it comes to tooth. But our body all comes from these three layers. Okay. So there's your primitive streak. Okay. This is when you become you got your trilaminar disc, in a sense. You got your ectoderm, your mesoderm, and your endoderm. And we are going to start folding. So we start out as a groove, and the top left picture is our groove because it's just starting to deepen a little bit. Then it goes to a fold, and then the neural groove starts to deepen, and then it starts to fold in on itself and actually fuse, which then gives rise, in a sense, to your digestive tract. It gives rise to your nervous system. Okay, so that primitive streak is the beginning stages of primarily everything that's kind of on the inside of our body, and this is just that cross section of that embryo. Okay, so the trilaminar disc starts out here like this, but eventually we end with everything forming together and fusing together. So the neural crest cells, okay, when we start folding and fusing together, when we get to this part here, we have the neural crest cells that give rise to our facial structure, right? So our face, if we didn't have proper migration of our neural crest cells, we end up with something called the Treacher-Collins syndrome, right? So where our eyes are placed, where our nose is placed, where our lips and our teeth, all of our structure of our head and neck, where it's supposed to, like if you were to say textbook, where it's supposed to live is because of those neural crest cells migrating where they're supposed to. When you have abnormal migration of those neural crest cells that come off of the folding and fusing of that tube, you end up with a condition that, again, is happening during our first trimester, because we're still in our first trimester, which would be a congenital malformation, is because of improper migration of those neural crest cells. Questions on that part?
Is it all coming together to form the neural tube?
The neural tube and the digestive tract and everything in between. Because remember, we have the mesoderm. All this is like the inner part of the body as well. And this is just a simple cross section, but it does form the neural tube, but everything also in between as well. Okay, so when we start getting to this point, everything should be kind of migrating to its normal position. So our head and neck should be getting into this proper position. Our digestive tract should be in this normal position. We're moving in that direction. When we're first here, we're just kind of getting our act together, right? But when we start getting into this point where we start to actually fuse, we now have for sure our neural tube is actually developed and come together. But the biggest part to remember from this part is that those neural crest cells is a big portion of the formation of head and neck. Okay, so again, I took histology and embryology and I just crammed it all together, so we're kind of jumping in certain sections. Okay, like sections that I feel like comes out of a lot of your word review books, and they're really pertinent to the development of head and neck. So we go back to our branchial arches, right? So this is our embryo that now we've gotten past the folding and the forming. Our tube is actually formed together. We're still in the first trimester. Okay, we're still in that embryonic stage, so we're starting to develop our head and neck, but it comes from those branchial arches. So this is our embryo kind of at a cross section. So we have our first, our second, third, fourth, and fifth, okay, branches as they go down. Now our major part of our head and neck development comes from our first 4 branchial arches. Okay? So if we talk about these different sections, our facial structure is going to come, like our maxilla and our mandible is going to come from our first branchial arch, right? So here's our cross section again. So, or this is our cross section. This is if we looked at it this way, we can see our branchial arches all coming together. So our first branchial arch is actually our maxilla, and our mandible come from our first branchial arch. Okay, so the top portion here is going to become our maxilla, and then the blue portion here is going to be our mandible. They are the same arch, but they start to separate and bulge differently. Okay, and then they come together and they start to fuse as they come into the center to that symphysis. So this is our mandibular symphysis right here in the center. Okay, our maxilla is going to start to fuse a little bit to our mandible and our frontal nasal process as it comes down. And then we develop our primitive mouth, which is our stymodeum. So if we look at a human, then we can see that looks similar, right? Here's our first branchial arch, which is our mandible and our maxilla, and our frontal nasal process actually forms part of our maxilla. So our maxilla comes from 2 different processes, and comes down to develop our philtrum, our nose, and the structures that are associated with the anterior portion. So again, if they were to ask branchial arches, just remember your first 2, okay, are going to come together, or the first one's going to make your maxilla, and then your head and neck is going to start coming from these second ones. Questions on arches? Is this all coming back a little bit? Sorta. Okay. So our mandibular process, so that Meckel's cartilage that was in our first branchial arch gives rise to like our mandible bone itself, right? But our mandibular process, which is off of that first branchial arch, gives rise to our lower face, our lower lip, our mandible, mandibular teeth, muscles of mastication, our tongue, and then our palatal and suprahyoid muscles all come from the mandibular process, which is part of that first branchial arch. Our maxillary process gives rise to our sides of our upper lip, our cheeks, our secondary palate, the posterior maxilla, which includes the canine and the posterior teeth, the zygomatic bones, and the temporal bones. Because of that process coming together, you can think about all the areas that are within that structure itself. Remember, our frontal nasal process isn't going to make our anterior teeth, or our frontal nasal process is going to make our anterior teeth. It does not make it from our maxillary process, because in that picture, it is including our front teeth there. So it's just the canines and the posterior teeth come from it. Because the frontal nasal process actually has to come down and make our primary palate, which is where our incisors come from. So, frontal nasal process, our forehead, our ridge of our nose, our primary palate, our nasal septum, our philtrum, and then all structures associated with the medial nasal processes. So within there is our development of our tongue. Okay, so our tongue comes from several branchial arches. So if we go back to our first original picture, you can see on the top part is a little bit more developed of that first arch, but all of our tongue actually comes from multiple branchial arches. So if we look at a tongue that we're used to seeing, we can see all the different colors associated with that first picture up above. So you can see the first branchial arch is going to give rise to a big part of our body of our tongue. Then we have the third branchial arch is actually going to be more of the back posterior portion of our tongue. The second one is gonna give rise to like our palatine tonsils, and then other structures underneath, kind of more the base of the tongue, is gonna be from branchial arches 4 through 6. So our tongue, huge portion of it comes from the first arch. The rest of it's gonna come from 2 through 6. And that's why we have multiple innervations, and why our tongue gets numb based on our anesthetic, because of so many different arches that are included with it. Because within these, it's not in this top picture, but if you go back to the other picture, you can actually see there was other nerve and blood supply to each one of those separate arches. So our innervation of our tongue with nervous system, with vessels and arteries is gonna come from multiple different areas, is why it also can be anesthetized by different injections because of that innervation that's happening with it. Questions on arches, tongues? Okay. So, palate formation. So, when we are developing our tongue, so our tongue is going through that process of that first top picture where you can kind of start to see the tip of the tongue developed all the way down to that bottom picture where it looks like a tongue that we're used to seeing. Our palate is starting to form, okay? So it comes in 3 stages. You have your primary palate, which gives rise to your incisors, which is from your frontal nasal process, which is the anterior portion of our palate. It's called that primary palate. And then the secondary palate happens, that is when the palate gets completed. So if our top picture here, we can see our palatal shelves are starting to drop down, and then our tongue is starting to develop, but it's still really anchored to the floor of our mouth at that point. So when those palatal shelves are going vertical, our tongue is still anchored to the floor of our mouth. Once the tongue hits a stage of its development and it starts to release from the floor of the mouth, is when those palatal shelves actually flip, okay, and they flip up horizontally, and then they're gonna start moving into each other horizontally to connect. So that only happens after the tongue releases from the floor of the mouth, is when we're gonna actually flip that palate. Okay, so failure of the palatal shelves to fuse to each other or to the primary palate is when we start getting into cleft palates. Okay, so that flipping of the palates is gonna happen, and it's gonna start coming together, but if they don't come together and fuse, so remember our primary palate is this top portion here, our secondary palate is the back portion. If we don't have fusion with the primary palate, we sometimes will get a cleft lip and or cleft palate double, right? Is because it's not fusing with that primary palate. Or we have failure of fusion of our primary and secondary palate. Okay. Or we can have where everything formed together except for the uvula. Okay, so that uvula is part of that forming there. It didn't fuse all the way, so you have a cleft uvula. So how many of you have seen cleft uvulas? Yeah, it's interesting. So then you think back to this, right? That happened during development. Actually, I've seen several in my career. So it's actually, you think about it, you see that, it should take you back to kind of in a sense that development of the palate, because everything's going to fuse together. And one of the last things to fuse is that uvula, right? And it just didn't happen, so you get a cleft uvula. You can have fusion of your primary palate but not your secondary, or you can have a unilateral where part of the primary palate fused but it didn't fuse all the way, and you end up with like a cleft lip, cleft primary palate. Okay, so again, these are all happening during that first trimester again, where the palate is forming, where it's fusing with the primary palate, which is part of that frontal nasal process, okay, and coming together, and that's just one of your common malformations that you can see in patients. So here's our primary palate, which is separated by a suture line, right? So this is all primary palate, and then this is all your secondary palate fusing together. And again, that's when the shelves go in vertical flip and come together. Now, I don't think I have a slide with it, but remember your tongue, when it releases from the floor of the mouth, if it doesn't fully release in a sense, that's where you get the tongue tied, right? The ankyloglossia. Okay, it's because that's usually the last part is our lingual frenum, is the last kind of, in a sense, attachment from the tongue being secured to the floor of the mouth. So when the tongue releases, that's how we get that lingual frenum, is that's kind of what's anchoring part of the tongue still. But if they didn't fully release, you end up with a shortened frenum, and that's when you get your tongue tied. Okay, so that's kind of a malformation that can happen with releasing of the tongue from the floor of the mouth. Palatal shells are still gonna flip and do everything, because there's still movement, but it didn't fully release, so now you get the ankleoglossia, or tongue tie. Okay, so that's head and neck, facial structures, formation of the tongue, palate, okay, big major portions of what we deal with. So now we'll talk about tooth development. Okay. So again, still within our developmental stage, we're still within the first trimester, because we know that in these stages we can have congenital malformations happen based on the stage, right? So we have initiation as our first, so we have to initiate a tooth, we have to develop something. So the body's telling it to make a tooth. So that's the initiation. This is where you end up with people who are congenitally missing a tooth, is because it failed to initiate a tooth, right? So it can be a primary tooth that failed to initiate, it can be a permanent tooth that failed to initiate. So the very first stage of tooth development is initiation. Okay? Then you go into bud. Okay, it looks like a bud on a tree when you're starting to develop a tree, start to get the little bud of where a flower is going to begin. It looks like that. It just has a nice little rounded part on the initiation. Then you end up with a cap, so it's starting to deepen a little bit. Okay. Then you end up with more of a bell, so we're really starting to deepen the tooth. And at that point is when we start to get into apposition. So apposition is development of enamel and dentin. Okay, so these are making the shape of the tooth. And then apposition is when we're laying down enamel, we're laying down dentin. Okay, so it's pretty much laying down the matrix. The enamel matrix or the dentin matrix is when apposition is. So development and then laying down structure in sense. And then maturation is when it's going to mature, right? Is once we started making the enamel, then we need to mature it. So it's only a matrix, it needs to be mineralized, and so that's the maturation. So these are your major stages of tooth development. Initiation, bud, cap, bell, apposition, maturation. So, top left picture is our initiation. Okay, so it's just starting to drop in. We can see in the picture we have our developing tongue, but we're just starting to drop in and make it, this is going to be a tooth. Then we go to the bud. Okay, start to round a little bit, so it's like on a tree. Okay, then we go into a cap, so it's just a nice little rounded cap there. And then we start to deepen it even more. We're kind of getting more of like a pointy end of the cap. That's when we become the bell stage. Okay. Then we go apposition, which is secretion of enamel, dentin, and cementum. And then maturation is the complete mineralization of those structures. So once we hit, let's step back to this picture here. So remember when we have, this is just taking the little corner of the bell here. We have different enamel or different cells that are based kind of on the inner portion. So if you guys remember back to the tooth germ of the tooth, right? We have the enamel organ, which is going to give rise to our enamel. We have the dental papilla, which is in the center, that's going to give rise to the inner part of our tooth, the dentin and the pulp. And then we have the dental sac, which is on the outside, that's going to give rise to the PDL and the cementum. Okay, so everything that you just kind of think about now that you guys know the structure of a tooth and where everything lies, hopefully this kind of helps you make more sense to what it was when we talked about it. But everything that's on the inside of the tooth comes from that dental papilla of the tooth germ. The dental sac on the outside is everything on the outside, the PDL, the cementum, and the enamel organ on the inside. Within that dental papilla, we have the inner enamel epithelium and then the outer enamel epithelium that give rise to the enamel and In this picture here, which is the amelogenesis, which is that production of that enamel, we start to form, this is our inner enamel epithelium, and then this is the outer enamel epithelium, because the inner enamel epithelium is going to start giving rise to the enamel, and the outer is going to give rise to more of the dentin. So amelogenesis is the production of the enamel. Those ameloblasts are cells that form from the inner enamel epithelium, because they start out as the inner enamel epithelium, they start coming together, they start lengthening, differentiating, and eventually they go from pre-amelioblast to amelioblast. And then the enamel is formed by the Tomes process from the DEJ to the outer layer. So amelogenesis is enamel formation from the ameloblasts. And on those ameloblasts, they form a Tomes process that starts to secrete the enamel. And the enamel forms from the DEJ, the dentin enamel junction, all the way to the outer part of the tooth. So it starts from the very center. So there are 4 layers of enamel formation. Again, you have that outer enamel organ, which outlines the shape of the enamel. The inner enamel epithelium helps to develop those ameloblasts. Then we have the stratum intermedium, which is the layer above the IEE, or the inner enamel epithelium. And then the stellate reticulum is the bulk of the enamel organ, or those star shapes. Okay, so we have, here's our inner enamel epithelium that start to come together to start forming the enamel. Okay, then we have our stellate reticulum, which is those little star shapes. And then the stratum intermedium, which is just the layer just above the ameloblasts that are going to start forming. Just the flat pink ones. Okay, so how we form enamel comes from those 4 major layers. So enamel, again, is 96% inorganic material. It is made of that calcium hydroxyapatite, is made part of the crystal of the enamel that gives it kind of its color and its strength. And then the enamel has 30% more of the calcium hydroxyapatite than our cementum and our bone and our dentin. So our cementum has the calcium hydroxyapatite, our bone also has it, our dentin has it, but our enamel has 30% more of it because it's stronger than dentin, right? It's stronger than bone and cementum. Bless you. So the enamel rods off of that Tomes process provide that strength to that enamel. So the Tomes process is laying down the enamel, and those rods is what give it its major strength. So if you remember, 96% inorganic material, there's the other percentages of water and inorganic, but the biggest part to remember is that 96% compared to the other ones that we'll talk about too that have that percentage, but enamel has more of the calcium hydroxyapatite. So dentinogenesis, which is the formation of dentin, okay? Dentin forms the bulk of the tooth, right? So the majority of our tooth is made up of dentin. It's formed by the odontoblasts. And then the preamelioblast actually cause the differentiation of the odontoblast. So these are the cells that are on the outer part of that dental papilla. They're just they start to line up together as those amelioblast are starting to line up and lengthen. And they go from these smaller cells to these lengthier cells. And the only reason they go to this is because the amelioblast are actually inducing the differentiation of it. So once they start to line up together and lengthen, then they start to secrete the dentin, and the dentin forms before enamel. Okay? Because we see here in this picture, the preamelioblast have not even differentiated yet to amelioblast. They haven't even formed Tomes process yet. So the dentin actually starts to lay down first. So our dentin forms, then our enamel forms after that. dentin is 70% inorganic material, so 96 for enamel, 70% for inorganic for dentin, and it's second hardest after enamel. Okay. And again, it has that calcium hydroxyapatite. We start to get those dental tubules or projections off of the odontoblast as it's starting to lay down the dentin. The dental tubules extend from the DEJ to the outer wall of the pulp, so that's where you get those dental tubules, where you get the signal of the hypersensitivity with patients. And then dentin stays vital throughout the life of the tooth. Remember, it does regenerate to an extent. If there's an injury to the tooth, you have like that reparative dentin. If you have a really severe injury to like the pulp area, you get the sclerotic dentin. But it is a vital part of the tooth. As long as the tooth is healthy and receiving nutrients, it will continuously make new dentin throughout the life of the tooth. So odontoblast bodies remain alive on the outer wall of the pulp. So as it reaches, it takes the dentin and it goes all the way down to the pulp. The odontoblasts actually kind of live there, if not dormant to an extent, or as needed, they'll come back alive, but they remain on that outer wall of the pulp so that they can continue to make the dentin as needed, based on the tooth's need. So, again, our DEJ is that connection between our dentin and enamel, and the dentin forms first, and then the enamel starts forming off of those tones process. So to develop our root, okay, as that tooth starts to deepen, as our bell starts to deepen, we start forming even further down, we start to make the shape of our tooth root. Okay? Our root is formed after the crown is complete and continues 1 to 4 years post-eruption. So as our kiddos start to form their permanent teeth, and as they start to erupt, remember the root is not fully formed. It takes about 1 to 4 years after it erupts for it to be fully formed on a permanent tooth. The root is derived from the cervical portion of the enamel organ. So as our enamel organ starts to form, we get that tip starts to come together and form, in a sense, kind of a neck here. Okay, and it's that tooth germ coming together. It's that OEE, the outer enamel epithelium, and the IEE, the inner enamel epithelium. They fuse together and start to elongate after the crown is formed. So we have the IEE comes together with the OEE, and they actually fuse, and then it starts to deepen, and that's what's actually going to give the shape of the root based on how it elongates and travels down. So the Hertwig's epithelial root sheath, which is the HERS, determines the shape of the root. So as it forms together and fuses and starts to travel down, it becomes that HERS part. It becomes the Hertwig's epithelial root sheath. And so based on how it travels through the bone, it's going to give rise to its shape. So when you have somebody that has a dilacerated root, right, it just took a different travel route. That HERS changed its direction. That's how you end up with those dilacerated roots, because the HERS determines that. So then once those start to get to the point where it's made its shape, the HERS actually kind of disintegrate away after it's like kind of made the shape. Those cells start to break off in a sense, and they become entrapped in the PDL, and then that's when the name of it changed to the rest of Mollese, because it's formed its shape, it starts to develop that dentin and the cementum, and then it's not, the IE and OE aren't needed anymore, which is the HERS. They start to disintegrate off and actually just get trapped into the PDL space. Okay, so then that becomes rest of Mollese. Questions? All right, so the cementum, it comes from the dental sac of the tooth germ, the outer part of the tooth germ, forms our cementum, and the cementoblasts form the cementum. It's thinnest at the CEJ and thickest at the root apex and the interradicular areas of multi-rooted teeth. Okay, so that CEJ where you guys feel like you're exploring your instruments is the thinnest amount of cementum on the tooth. That's why we want to preserve our cementum with our instrumentation, because it is very thin at the CEJ, but if you went further down the root of the tooth, it starts to thicken. We get more cementum in those areas. The cementum does continue to form throughout the life of the tooth, just like the dentin it does continue to replace it, and it's 65% inorganic. So enamel was 96, right? Dentin was 70, and cementum is 65%. Still has a calcium hydroxyapatite, but it's not as strong as enamel and dentin. Enamel's the strongest, dentin's second. Okay, so the periodontium, okay, we talk about periodontium with our patients or with each other. Remember this, the components of our periodontium includes our cementum, our alveolar bone, and our periodontal ligaments. So those are the part of the tooth that we're trying to preserve with our NSPTs or maintenance, perio maintenance, or preventative treatment. We want to preserve our periodontium. So we're trying to preserve our cementum, we're trying to preserve our alveolar bone, and we're preserving our periodontal ligaments. So when we talk about periodontium, it's three components. So you think about what you're trying to do with your NSPT, it would help you remember what is a component of periodontium. So periodontal ligament attaches the tooth to the alveolar bone, and those Sharpie fibers, which is part of the PDL, is the part that's embedded into the bone and the cementum. So the end of the periodontal ligament we have is the Sharpie fibers. Okay, so we have the periodontal ligaments, everything in between, but at the end we have Sharpie fibers, and they have to attach at a 90-degree angle into our alveolar bone and a 90-degree angle into our tooth, into our cementum. Periodontal ligament also helps to maintain the shape of our gingiva in relationship to our teeth. So we have periodontal ligament around each of our teeth, but we also have a periodontal ligament that's within our gingiva as well. So it maintains the shape of the papilla, it maintains the shape of the gingival margin, the shape of the tissue in between the teeth. So periodontal ligament's not just the part attaching the tooth, it's also the gingiva as well, which is why we do our gingival description, and then we include that as part of our treatment with our patients so that we can help maintain that shape. It also acts as a shock absorber for our teeth, and then it comes again from that dental sac. So everything on the outside of that tooth germ gives rise to our periodontal ligament. So our main principal fiber is the alveolar dental ligament. Okay, so alveolar bone and the tooth. Okay, is our major principal fiber is the main portion of the periodontal ligament. But it is then broken up into 5 subgroups based on its location on the tooth. So our alveolar crest group is the very top of it, right? It's attaching the tooth to the alveolar crest, the tip of the alveolar crest bone. Our horizontal group is the next one underneath it, so it's going straight across. Okay, so the tip is alveolar crest group, horizontal group is just the straight across horizontal one. And the majority of our PDL comes from the oblique group. Okay, so we're going at an oblique angle pretty much down the rest of the tooth is our oblique group, going at an angle. Our apical group is at the apex of the tooth. And then our interradicular is only found on multi-rooted teeth, right? We wouldn't have an interradicular on a single rooted tooth. So most teeth have the 4 groups, but we do have, of course, our molars that would have our interradicular if they are multi-rooted. Then we have an interdental ligament, right, that goes between cementum to cementum, so our teeth are kind of anchored together by our interdental. Okay, so our periodontal ligament is the one attaching the tooth, in a sense, to the bone. Our interdental attaches tooth to tooth, so it goes cementum to cementum. And then we have our gingival fiber group. Okay, again, they support the marginal gingiva, they support the shape of our papilla. So our circular group is kind of giving more the shape of our papilla. Like in this picture here, they're kind of these little dots here, but then they are encircling the gingiva. Then we have the dentogingiva, which is going from the tooth to the gingiva, so it's kind of helping with the shape of the tissue. The alveolar gingival, so it's going from bone to gingiva. And then the dental peristeel, okay, is going from the tooth itself to kind of the alveolar bone. And so you just take the tooth, take the words and just break them up, and they should be able to tell you their location of it. But just remember, we do have it within our tissue because it is an important part of our shape of our tissue and the health of our tissue. Questions on PDL, cementum, enamel? So, our oral mucosa, again, it's the three major portions. Our oral epithelium, our lamina propria, and then our submucosa. And this is talking about kind of our tissue within our oral cavity, have the different types. Our lamina propria, which is the dermis portion, is going to be holding a lot of our nerves and our blood supply. It lives in that lamina propria. Okay. And then some parts of our oral cavity don't have a submucosa. So we have probably more of our cheeks have more of that submucosa versus something like our hard palate is going to have a very maybe thin, if not present, submucosa, which is the fatty layer. So you just kind of think about its location in the oral cavity can tell you the different types that are there. So within our epidermis, we have that keratin layer. So when we talk about patients that have a hyperkeratination, where they have like the irritation of the tissue, the keratin layer's got thick and deepened, and so that's based on that keratin layer. Then we have the granular layer, the prickle layer, and then the basal layer. So that's just in the epidermis, which is just the top portion of our oral mucosa. So we have in our oral cavity different types, and they're all the stratified squamous. Okay, so all the epithelial tissue in our oral cavity is stratified squamous, but then we have non-keratinized, orthokeratinized, and parakeratinized. So our differences really between them all is whether or not they have a granular layer. So this is our non-keratinized. This is our orthokeratinized because we have a granular layer, but we don't have any nuclei in the keratin layer. And then our parakeratinized have nuclei in the keratin layer. And it's kind of, again, based on its location in the mouth, the type of abrasiveness that it might take from chewing and eating. The tongue has a different layer than like our cheeks, which is our lining mucosa, might have a different type of keratinized layer based on its forces that are going to be pushed onto them. So our lining mucosa is that barrier between the oral cavity and the deeper structures, and it's found on our buccal labial tissue, our floor of our mouth, the ventral surface of the tongue, soft palate, and the alveolar mucosa. So if you think about areas that are soft, moist, cushiony, elastic, that tells you it's a lining mucosa, because our cheeks are the shiny, soft, stretchy, smooth, right? That's going to be more of our lining mucosa. Our floor of the mouth is the same way. It's stretchy, it gives, it's very soft. Our ventral surface of our tongue is the same way. Soft palate, alveolar mucosa. Okay, if you think about what it looks like, what it feels like, you guys have seen enough of the oral cavity that you can probably figure out which is lining mucosa based on its appearance. Then our masticatory mucosa is found in areas related to mastication, right? Areas that are going to be working with our chewing. So our attached gingiva, our marginal gingiva, the dorsal surface of our tongue, and the hard palate all have this type of mucosa. So if we think about firm and resilient to mastication, resilient to foods that we eat, is going to be more masticatory than it's going to be lining. Because the lining is going to be easier probably to puncture and get through versus something that can take a little bit more force. So you think about the oral cavity that's more firm, like our attached gingiva or our hard palate, and then areas like our tongue, the top of our tongue, the dorsal surface, is going to be more stronger to food than maybe our ventral surface would be. Okay, so you guys should remember your oral structures, right? So you have your alveolar mucosa is that soft, shiny, stretchy part. Then we get into our attached gingiva, which is where we see all of our stippling. And then the junction between them, again, is that mucogingival junction that we can separate out by pulling on the cheeks. But it's that junction between the alveolar mucosa and the attached gingiva. So alveolar mucosa would be lining mucosa, attached gingiva is the masticatory mucosa. Okay. You guys remember back to head and neck, this is probably the hardest question for everybody to remember in the first exam. It is every single time. But hopefully it makes sense now. It comes back to, right, where we have the incisive papilla that we burn on pizza, our palatine rugae, which is the folds, right? And the median palatine raphe. The raphes are always the connection, like a suture line in the sense of the tissue. It's called a raphe. So the median middle palatine raphe, okay, is the major structures of the palate and their proper name, right? So when you're doing your intraoral exams and you need to describe a lesion, and it's near median palatine raphe, right? Or it's on the palatine rugae lingual to tooth number 10 or 7, right? So you should be able to remember these structure names to use in your intraoral exams versus just saying, the palate, right? So those are your structures to remember for your IO exams. Okay, so our gingiva, again, we have our marginal gingiva, and then remember we have our free gingival groove and our free gingival margin. So everything within the dotted line is our marginal gingiva, but everything superior to that, right, that's the groove, the free gingival groove, because it's a groove, and then we have a free gingival margin, which is where we're reading our prodepts. Okay, so all of that together is considered the marginal gingiva. Questions?
Do you know the specific weeks in which the cleft palate, has potential for deformation?
I believe it's like around like 5 to 8, or week 5 or 6, somewhere within that.
Because I remember seeing that as a question somewhere
Yeah.
or something. That